It's okay. And then, okay. Just let me know when you think it is.
Just get on the screen. Oh, no, I'm on the wrong side of the camera.
You are.
This he's already joined. Okay, that's a really small.
It has a personalized idea. It was a secret certificate.
You're writing about the JBI. Apparently it's lovely what you wrote for the JBI.
Yeah, it's still doing well. We went
Your bit was wonderful. Apparently. No, his parents wrote something. Oh, Jimbo's done an excellent job.
That one, I want to revise.
Yeah.
Oh, right.
She's not so good.
Sure, yes. I would not.
Yeah, and then
Oh,
after
yeah.
they
Oh, okay. There's a couple of people online. Three, I think. No, he's writing a little, it's 20 years since the JBI was established, and so the original editors are meant to write something, so Jingbao's written his and I'm trying to work out what to say in mine. Oh, right.
I've been given a lecture. So I have not want to revise on Wednesday.
Oh, right.
Yes.
He's a medical student. Because that's a slide showing secondary medical school.
Oh, yes.
Would you need
It's just come out.
Yeah. And then he's
Healthy, yes.
Tēnā koutou katoa. Oh, now you can see me. No mai haere mai. Ko Linley Anderson tōku ingoa. Welcome everybody to this bioethics seminar. My name is Linley Anderson. I'm a staff member at the Bioethics Centre normally, but at the moment I'm currently acting Dean of the Dunedin School of Medicine. It is my great pleasure to introduce to you Dr. Rawiri Jansen. Now, he told me to tell you just to Google him rather than give him any introduction, but I can't let that go. It is my great pleasure to introduce you because he's been doing incredible work at both grassroots and national levels. And he's working hard about improving equity within the New Zealand healthcare system. He focuses on providing clinical leadership towards Māori health equity as a GP, but you're also looking at other factors that impact on contribute to poor health outcomes for Māori and ways of improving health outcomes. And so I'd like to hand over to you immediately. And I'd suggest if you want to Google them, look up 100 Māori leaders. That's where a really good place to start to read about Rawiri. Thank you very much.
Kia ora. Nō reira ka mihi kia tātou e tau nei. Ka mihi ki tēnei kaupapa e whakawhaiti nei a tātou ka mihi ki te whare. Me ki ko tēnei whare wānanga. E arotahi nei ki tēnei kaupapa o te hauora mō mai Māori. So yeah, just acknowledge the university, the place where we're meeting, and acknowledge the intention, which is to have a robust conversation. I've got permission to swear. Shout out to everybody online. Just put an emoji in there going, what the? And yeah, so it's good to be here. I actually went to Otago University. I've been named in the Senate. You should Google that. Named in the Senate. It's a thing. I'm going to cover a few things and I might just do it a little bit out of order, if that's all right. Permission granted. This is, I've got an elevator pitch that for me, I did this in 2018 and it said, imagine that in 2040 we're celebrating 200 years since the signing of the Treaty of Waitangi. We're celebrating, not protesting. We're available to protest if we don't get this shit done. But imagine that we're celebrating. And we're celebrating because we got so much done. right? In 2040, we're looking back and going, yep, we can describe what equity looks like in terms of, you know, different populations, and it might be in terms of housing and housing ownership, or it might be employment, it might be income, or it might be in justice and corrections, it might be in the health system. And we can just describe so much equity, right? Now, if we wanted to do that, one of the things you'd look at is different groups in the population, and it might be kids who turn 21, right? So this beautiful diagram says, imagine what it's like. Here's this kid who turns 21. And we would be thinking about what equity features you'd see for all 21-year-olds in 2040, right? And there'll be academic achievements, and there'll be employment and income and all those things, right? Now, if you want to do that, there's a bit of work we need to do with the universities, make sure that our kids are getting through universities and polytechs and getting their apprenticeships completed and so on. And so actually, we've got to do a bit of work with the secondary schools. We've got a lot of work to do with the primary schools. Actually, you know what? Early education is really important. Actually, we've got to start with all the hapu mama. So back in 2018, 2019, the provocation was, if we want to see some really good stuff in 2040, we have to start now. And the provocation is also, who might we start with? So thinking about all those hapu mama in 2018, 2019, and make sure that they're getting the best start, and make sure they're getting good midwifery support, and make sure they're getting pertussis vaccinations, and make sure they're getting, you know, the things that they need to have a really good pregnancy and a good outcome in terms of the birth. And then we're going to look after all these babies, make sure they're immunised, etc., etc. So that's the fantasy. And we didn't get everywhere where I wanted to, but I just want to kind of have this, you know, kind of, that's the vibe in terms of the provocation. The second slide then is just the, you know, the equity meme that we see a lot of. And can I just check everybody's in favour of this kind of thing? Make sure that the right number of boxes go to the people who need boxes. Are we good? Right. Mm-hmm. But most of the time when I go to, I don't know, a big conference, okay, there's a lot of people who don't believe in it. There's a lot of people who believe in equality. Let's just give everybody one box. That's fair, right? And right now we've got a government, I think, we've got a context in which we really need to own the space, you know, that we want to describe about what is equity, and how do we address inequity, and what's required in you know, distributing the boxes. Because in the health system I work in, we do a little bit of work, we get a little progress, and then I turn my mind to something else. You know, I'm working in acute rheumatic fever prevention or whatever, and you turn back, you go, fucking get off that box. I asked you to get off that box so we can have that box over here. I turned around and it's gone back the other way. So, you know, actually, that's what's happening right now, right? We have to have conversations about what is equity, what is inequity, and how do we, you know, bend towards equity. All the time we've got to bend towards equity. It's about the boxes, the number of boxes. It's about the resources that are required so that we get better outcomes for Māori, for Pacific, for disabled, you know. I'm not down too much on the rural thing, you know, like I'm just saying, but really when you look at the rural inequities, it's really Māori inequity that drives that at a high level. I mean, yeah, there'll be times where you can contest it, but there's a lot of millionaire farmers, you know what I'm saying? There's some stuff there you go, actually, the people who are really wealthy in rural settings, they're doing all right. Just saying. So I do want to, we have to unpack some of these boxes, some boxes of metaphor in them. Anyway, another provocation for you. We are a nation of 1 million, right? So you might rely on the statistics announcement, which is their estimate resident population from last year. I think, you know, what's the number? Somebody got a number for me? Well, I think they were saying 904,000, but you know how many babies 30% of all babies born are Māori babies, I'm just saying. So since 2023, we've added a whole lot more Māori babies to this. But anyway, I'm including Gold Coast, right? So the Māori Nation, we have some who are living offshore, but they are part of the Māori Nation. The Māori Nation's 1 million, right? And so the provocation I've got is that we as a nation are entitled to a health system that meets our needs. Yeah. Needs is a hot button issue, isn't it? Needs. But I want to say it as a political statement. We're entitled to have a health system that meets our needs. Yeah. And the beautiful photo is, it's from a few years back. But what I'm trying to say is there are lots of Māori doctors. We need to do a similarly good job in terms of the other health professions. We need to see more Māori pharmacists, physiotherapists, nurses, nurse prescribers, nurse practitioners, psychologists. We need to have a Māori health workforce that can deliver what I think Māori Nation's entitled to. So, full disclosure, I've got a gig working for the Tū Nation. Right, so Tū in the central North Island, around Lake Taupo, Taupo, Turangi, yeah. And the Tū Nation has an intact hereditary ariki line that still exists today. So when iwi Māori partnership boards were created, the Tū Nation said, right, the Ariki's office determines that. So the Ariki said, all right, we're going to have 5 people, this is who they are, right? And there's no contest, there's no big argy-bargy. Some of the other iwi Māori partnership boards are contentious or contested or, complex. And I get that, because certainly where I come from, I'm Ngāti Hinerangi, Ngāti Raukawa, and if you're on the Radio New Zealand app, you'll be seeing that my cousin is going, hang on a minute, we've got some issues here with this quarry. This quarry's been non-compliant with every single requirement on a quarry forever, water quality, a whole lot of stuff. So, Ngāti Hinerangi, we just recently settled, but we want to exercise that tinoranga tiratanga that we should have, and sometimes it will be contested, I get it. And that will be true in 3 waters or as many waters as you like, and it'll be true in health, and it'll be true in education. Those contests are, I acknowledge they exist. But in Tū there we go. The Tū Nation is saying we should be in a situation where we can design and deliver and own health services in our nation's territories, right? So formally saying we think we should be owning the hospital. Well, turns out they do own the hospital. They own the land, they own the buildings. They're saying we want to go further, right? And so that's a beautiful aspirational kind of 2040 kind of a challenge. And I want to be part of that. I want to support that, autonomous, independent nation, Tū to exercise their authority in their own lands. So lots more Māori doctors, beautiful thing, and thank you, Otago, making your contribution towards that. And I want to see that, in a much broader sense. So there is inequality right across the whole system. It's a high-level summary. Anybody contesting this? Any online chat? Shout out to everybody online. You have to use the chat. Don't unmute yourself. Just type.
We'll be
Okay.
watching out for it. Oh, there's one.
Deadly. Thanks, Alistair.
No, you said just, you have to highlight again so that it works. Yeah.
There we go. Technical challenge. So acknowledge that somebody else developed this slide and has made these assertions, but imagine that if we are going to address inequity, and we might call that a pro-equity approach, there'll be some reliable characteristics of a pro-equity approach. So I'm down with this slide, and I'm really interested in a couple of parts of it. Address racism. We have to talk about racism, yeah? And that's not, it's hard because Luxon's he's gonna feel it that I'm calling him a racist. And that's true. And part of that is that's deeply uncomfortable. I don't know if any of you have done it and had a look at what we do and the contributions that we make, but I don't know anybody who can go that they've never contributed to the racism in our society. I've done it. You know, I can tell you my identity is Ngāti Hinerangi Ngāti Raukawa, but I can walk through this world as a white man. Yeah. And I have done things which I regret. And I think, fuck it, we should have done better there. That's on me. And, you know, that's that critical self-reflection that we've got to do. And so, you know what? We've got to own that. We have contributed to this thing, institutional racism or racism in the healthcare system. And it's uncomfortable. It better be uncomfortable. But we have to do that to be able to get to a place, you know, so I think that's one of the things that we're facing right now in 2024 is how do we stand up and own that and do better? Because right now we are getting challenged about that. So, you know, what is inequity and how is it generated and our contribution to that, it does end up in a place where we've got to own that racism. And I don't want to let anybody else go, no. I'm not saying you're racist. Fucking come on, people. This racism exists because we contribute to it or we allow it or we don't stop it. So we got work to do. And as we do that work, sometimes we do good and sometimes we do not so good. We've got to be honest about that. So anyway, that was that one. We do have to address, if we want better health outcomes, we actually have to address the social determinants of health. So thinking about tū whare toa, and they've got this wicked idea of saying we want to own and run the hospital, and you look at some of the small rural hospitals around the country, you go, don't do it, you're going to lose money, you know. But there's good examples of it can be a real basket case in terms of the quality of healthcare services, and the owner just goes down the tube financially. So that isn't the intention. But you just imagine just for a minute if tū whare toa says, all right, Taupo Hospital at the moment, the land and buildings owned by us, but we want to change your lease whatuora and we want to develop the campus, and we expect to see the tertiary sector coming in. We want to have a campus that's going to train and grow the next generation of health professionals, you know, nurses, and there should be some GP, and there's got to be some rural hospital generalist training there, and there's got to be some, you know, all of the training opportunities that should be happening there. So let's build that campus. So actually what's sitting behind that is tū whare toa nation is going, we've got to make sure that health is something that we're employed in doing. If that's building the buildings, if that's looking after the grounds, if that's supporting the tertiary education sector and doing the stuff, we've got to see employment for our people, right? And if that happens, that's an incredible contribution to the health outcomes for tū whare toa. Yeah, it's not directly from anything that you're doing inside that hospital. Right? You know, it's good. I'm really happy that you do a really good job inside the hospital. But imagine that we're actually employing lots of tū whare toa, right? Because Whatuora is the biggest employer in the country. It's 90,000, sorry, Leicester's in charge. It's not 90,000 anymore. It's less than 90,000. You know what I'm saying? My heart goes out to them. There's redundancies in there. You know, it's a sinking lid, and it's a fucking, somebody told me it's the Hunger Games in there. Okay, but say it's 85,000. It's the biggest employer in the country, right? If you go to Dunedin, the biggest employer in the city is health. Is that true? Because you've got a big university. Okay, university health. All the health university ones are in health, right?
Yeah.
If you go to South Auckland, the biggest employer in South Auckland is health. And all I'm saying is Māori Nation, same thing should be true. The Māori Nation should be going, the biggest employer for the Māori Nation is health. But it isn't right now. But you know, that is how we got to address a health outcome, is by making sure that we are being employed and we're getting our income and all the rest of it through the biggest business in the setting. Design for equity from the outset. Right, so that's cool. And then shout out to self-determination, you know, it's just, all right, so those are the features that I'm looking for. I used to work for Te Aka Whaiora till we got disestablished. They said, oh, we'll lift and shift you over to Whatuora. I said, fuck off, I don't want to work for Whatuora. No, that's not right. And so I said, oh, I was going to, go personal grievance and go to employment court. I said, the Supreme Court is waiting for this case. The Supreme Court, Joe Williams, I've known Joe forever, is just waiting for this case because it's going to be about mana and tikanga and integrity. So you can't just lift and shift us and put us in Whatuora. And it was a really compelling case until they said, oh, you got to read the Health Transfers Act 1993. Fuck. All right, I give up. I'm out. So I resigned. So and glad that I'm not in there. Anyway, I thought this was a good report they developed in there about Māori health priorities. I'm sure you guys are going to read it. And it said cancer, first 1,000 days, mental health, and long-term conditions. So they went through a process to prioritise, and I want to talk about prioritisation shortly. This is the halfway mark. Okay. Although everybody in the room, you might get a cup of tea break. All right, I think the sausage rolls. And you can just sort of read those bullet points. I wasn't an author of the report, but you can sort of see that all of these kind of key highlights really resonated for me. And so I was here to talk about ethics, wasn't I? Okay, good. So I thought, oh, well, we could talk about, there should be a few case studies. There's lots of case studies, but a recent one. So I was involved in, we talked about the COVID disrupted our healthcare services quite significantly. And so we had a slogan at the time that said, build back better. We don't want to go back to business as usual. Business as usual is fucking terrible. It's really bad for my people. Let's not go back to usual. Let's build back better. And so one of the areas we got involved in was the waiting lists. And there was a whole lot of things that got interrupted because of, mostly because of COVID, but that intersects with the ways that we do the things that we do in the health system. There was the long lockdown in Auckland where the hospital had effectively stood down a whole lot of people, right? Surgeons and all of the operating theatres and so anaesthetists and all the rest of it, but kept them on full pay. And so, that kind of riled me up, just honestly. And so at least in Auckland, I don't know your experience down here, but we said, so in the next lockdown, we go, your normal roles, you can't do that. But you've got a choice. You could take leave, because up to then we were giving everybody their full entitlement to leave and said, oh, and you can bank all of your conference leave, you can bank that. Just, it used to be a rule was 2 years. Oh, well, you make it longer, 2, 3, 4 years. Okay, you can bank that. And so you sort of send all of these people, really highly skilled people, home on full pay with all those entitlements, building out, fuck, that doesn't make sense to me. You've got a choice. If you want to come to work, we've got some work for you. It's called vaccinations. And, so we'd have mass vax things, and we had I met some anaesthetists and some surgeons, not all of them, but there was a few who went, yeah, I'm up for it. And then there were some people who kind of go, oh, that's a bit beneath me. But, it's supposed to be like a pretty emergency kind of a space. Let's all get in and do the work. Building back better, as part of it is to look at what we do and how we do it, the culture of the health system. And for us, we were kind of activated into looking at what happens with waiting lists. And so the evidence was pretty clear that Māori and Pacific wait longer. Okay. And so we started a project in Auckland, and we had a couple of different prioritisation tools. I'm a blunt tool, eh? I've only got 3 tools in my toolkit. I've got a hammer. You know how to use a hammer, eh? Right, everything looks like a nail. You just hammer the shit out of it, right? I've got a spanner. You know how to use a spanner? You jam it in the machine to come to a crashing fucking halt. That's how you use a spanner. That's right. And I've got a screwdriver. Screwdriver. It's a very nuanced tool. I can dial things up. I can dial them down. I can tighten. I can loosen. Right. So, anyway, I was more like a hammer in the surgical wait lists thing, and so as we're going into it, what we're trying to understand is what do we do about Māori waiting longer? Because that's depending on what priority you are, that can be quite a significant contribution to your outcome. But specifically looking at sort of the P3 onwards, the P1's like, fuck you, get this shit done immediately. You know, we're talking days, a week, whatever. And P3's less urgent, right? But why would it be that Māori and Pacific are waiting longer? And so some of them, you know, we got really good data, and it was hundreds of days, hundreds and hundreds of days. And as we went through this process, then we discovered things like suspend list. And so I was at the meeting, I said, what the fuck's a suspend list? What's that about? Well, it's supposed to, the rules on what suspend is when somebody says, oh, can you take me off the waiting list because I've got to go over to Australia and visit my auntie's got cancer, or what, there's reasons that people just go, look, I'm in that P3 space, but this date isn't going to work for me. Just take me off, stand me down for a while. But what we discovered is that it's been used for a whole lot of other purposes. Some of them kind of evil. Sometimes it wasn't evil, but it was this person needs to have a MRI or an ultrasound or something else, and there's a delay in getting those things done. So suspend them until that's done, which isn't a proper use of the suspend list. But anyway, so we could straighten that up, and part of that is making sure that our booking clerks, everybody knows what the rules are on suspend list. But there was suspend list that was being used for really incorrect purposes. And so uncovering that and talking to those who were using it in the wrong way and making sure that our system's kind of starting to have honest conversations about the lists and the waiting and what suspend was used for, all of that stuff. Part of it is that you have to go before somebody even gets on the waiting list, right? So there's how people get on the waiting list in our system is interesting and complex, and also has inequities built into it, right? So access in primary care is an issue. Even within primary care, if you do get access, some people are getting more referrals than other people, et cetera, et cetera. But anyway, so the project was kind of just looking at, okay, once people, like we're interested in the stuff that happens before referrals, but we're kind of responsible for the stuff that happens in the referral space, right? So these people are on a waiting list, and we've got to start making sure. So we did some really interesting things like getting nurses to be in a more influential role in that, and ringing up patients and making sure they're all set for their surgery. It just makes a remarkable difference if you talk to the patient. And finding out for some of them what the barriers to getting the surgery were, and it might be cost of parking or childcare or other family members. And so, we had Māori and Pacific nurses who were just, naturals at being able to have these conversations with patients, help them identify what is the blockage, and then help them identify what things are going to make a difference. And so get in place the support so that person was able to get in and get their surgery. And part of it was our prioritisation tool. And I did mention that on the blunt instrument, didn't I? Right. So I don't know, was that Seymour who got all jumpy about the evaluation about the prioritisation tool? So from within the health system, we're going Māori and Pacific wait longer. We're identifying an enduring inequity in our system there. We want to understand it. We want to it's amenable to change. Let's do the right thing and get it fixed. And you know, so it blows up in Parliament or on Radio New Zealand or whatever. And so Whatuora got this evaluation done. It's a bloody good read, but I want you to read it as advice to me. You know, I was involved in those meetings that developed these tools and talked about it and deployed it, and tried to address it. And I received that report as a critique of what we did. You know, I think it's fantastic that we could do it. And at a high level, what I want to tell you, if you read, I'm going to try and bend you towards my understanding of it. I think what they said was, yep, there's evidence of inequity. Yep, you tried some stuff. The evidence of whether or not the stuff you tried made a difference isn't robust. And did you do any harm? We don't think so. Right? You've read it. Peter's going to read it now. He's going to get far. It's a really interesting report now. And it's got these appendices. Oh no, that's just more on the report, yeah. So kind of really authoritative, formal, robust approach to it all, right? Oh, hang on, I told you there's 4 things, eh? I think there's a 5th one in their report. I think the 5th thing they told me was, keep going. Do better. Yeah, do better, keep going. Because at the end of all of this, I better show you this is the Appendix 3, right? Oh, Appendix 3. So it's Jackie Cumming and Tim Tenbenso, and implicit and explicit priority settings, right? So we've got to talk about the implicit, you know, a lot of this comes from the historical, cultural basis of our healthcare system, right? And we do need to unpack that. It talks about CPAC, the Clinical Priority Assessment Score, something like that. Like these guys, they're academics and they're really nice people. There's no swear words in there. And they kind of give you the history of what it was. It comes from the time of New Zealand Health Committee, was it? National Health Committee. And so the intention of it, and it was seen as something of an innovation internationally, all the rest of it. Along comes me years later, blunt tool, and I go, yeah, fuck you, I've seen that CPAC score being gamed. And so they talk about gaming, they talk about bias and gaming. So it's a really beautiful appendix, and I recommend you read it. So at the end of it, I'm going, right, so the inequity was real. We tried some stuff. The evidence about what we tried, did it work, is not robust. But I think the report says do better, keep going. And the response from the system was stop. Yeah. And so that's I think it's a good case study. There you go. Any questions? No, I haven't finished, haven't read it, but I'm sharing. We'll start with people in the room.
So this was the attempt to
Yeah, we're recording this. If you're here, you've given permission.
So the level at which this work was to take into account ethnicity, wasn't it, as a weighting factor?
Yeah.
In the score. Yeah.
Yeah. I mean, formally, we said that ethnicity was one of the factors, and so rurality was one. I mean, I've already said to you, rich rural people, I thought were doing okay in terms of the referral and waiting list and all the rest of it. I thought, actually, when you look at rural and the contribution into the complexity for them being in this waiting list and waiting longer, I think it was Māori. And so, rightly, you want to kind of contest, okay, but both things can be true. To what extent does each contribute? And so that, again, I think you might look at what we were working on and our sort of week by week committee meetings and the data that we were getting. And I think you could critique that and say, actually, you know, there's more work required to be able to understand what is the contribution to the waiting list long waiters that comes from rurality, that comes from being Māori or Pacific. Yeah, but the prioritisation tool, blunt as it was really looking at ethnicity, rurality, maybe deprivation. And so politically, then you want to go, oh, no. We were really looking at deprivation and rurality and ethnicity. Yeah.
We've only had a small, in terms of the percentage weighting relative to, say, clinical need, it was a reasonably small percentage.
Yeah, sure. Yeah, because if you're P1, we got to get you done. And if you're P2, all the P2s are priority, we can't fuck around on that. So you're getting into the P3 and saying, why are some of these people waiting 365 or 605 days or whatever? So at that point, we've got the capacity to go in and look at what's happening. And then we discover things like, actually, this person who's been waiting for 605 days has actually been waiting for this procedure for longer than that. They've been on the waiting list and then suspended, and they're back on the waiting list. And so then we had to go, well, we've got to make some rules that make sense here. And that's the cumulative time since you were referred and done it. So there's some stuff, but and I think gently you're saying, and you didn't make much of a difference.
I don't know. I mean, is that what the evidence actually is, or do you not really accept that? I mean, maybe it was too short a period to find out.
Yeah. So, I mean, my colleagues, I think, give us a critique which says the evidence that you made a difference is not robust in a kind of academic, scientific way. In terms of what I'm seeing while we're sitting there and measuring stuff and being able to go to urology and cardiac and each of the surgical silos and say, this is what we saw a month ago, and week by week we've seen this. And I think the culture change was we took it away from the individual surgeon going, this is who I'll do next week. My list next Thursday will be a short list because, something good on Thursday. Oh, fucking, I'm just kind of mischaracterizing every surgeon. And, some of my best friends are surgeons, but the idea that the surgeon was in control of who would be seen, and that wasn't robust, right? That was influenced by a whole number of factors, and the output of all of that non-scientific control over the who gets surgery was some enduring longer wait times for Māori. And I'm going, that's not acceptable. And so the culture change that I think we've managed to do is actually take some of that power away from the clinician. We had Andrew Connolly involved in something. He's a surgeon, and I count him as a friend. And so trying to clear that up and go, we're going to help the surgeons to determine who is the next patient on their list, right? So rather than them just sorting through and trying to figure out, and look, the more discretion there is, the more inequity we see, right? We see less inequity in a roadside accident emergency with an ambulance than we see in primary care. The more discretion there is, the more inequity we see. That's just a rule of thumb. So we need to take some of that discretionary power about who gets next and go, this person's been waiting, these people are all P3 and they're on your list, and these people have been waiting a long time. We want you to get them on your list, right? Not just go through on the things that you like doing or whatever. So we, getting the booking clerks powered up to be able to have those conversations, getting the booking clerks powered up to go, this is an inappropriate use of the suspend. They need to talk to somebody, right? So they know they could do that, and it would come to the right place, and then we could act on it and talk to that clinician and say, that's not what suspend is for, don't do it anymore, right? So we got some culture change stuff in there, but the evidence isn't strong that it's, reliably, robust.
So I just had a comment on Neil's suggestion, which I think the point that Neil might be making is because the ethnicity was given a low weighting to equity justice, it would have been really surprising if you detected an effect from that. So if there'd been a bigger weighting to them, maybe there would have been. So that would have been my response to the report. Say, of course not, it didn't have that bigger weighting. I was thinking, so Neil was involved in the CPACs when they started.
Oh, yeah.
Sorry, Neil, many
That's
years ago. So 25 years ago or something.
Yeah.
And what they were aiming at was, to me, something similar to what you're describing, which is here are the criteria that these are the rules that we're playing by.
Right.
And here's how it's, and over time, it's completely fallen by the way.
So it went from performance and relevance to bias and gaming. Not just surgeons too, you know. Right, one more in the room.
Yeah, I'm rather whistleblowing here because I'm
Turn the camera on.
Reading.
Whistleblower.
Carl Elliott's book on whistleblowing at the moment. And I'm very aware that as a long-term colleague of many of the people I have been referred to, the deal I get for my health needs is sometimes quite disproportionate to other members of my family who live in Auckland with very similar health needs and who have developed among themselves an ethos of the type you either go private or you wait forever. And they develop that just out of their lived experience, whereas I've never developed that because I'm quite aware that my ex-physician has actually made a subtle and difficult to isolate or identify difference to the way I progress through the health system with my multiple
Right.
health needs.
Accepting that, cutting you off too. I accept what you're saying. I think, you know, I think there's people nodding in the room as you're saying it. And the truth is that it won't be just you as an individual.
No,
That those kind of benefits accrue to populations within our communities, right? And that's an uncomfortable conversation that we need to have.
well, it's an uncomfortable conversation with myself.
Yeah.
I think there's something deeply wrong here, and yet I feel disinclined to object because I benefit.
Right.
And
let's play with
also
that.
because my wife is a squeaky wheel. She's a stroppy woman. And if they try and do something which she thinks is not for my benefit overall, she takes them on. And taking her on, I can assure you, is not a comfortable position to be in. So I get good treatment.
So shit, it's in here. It's the earlier in that appendix. It's inter-service prioritization, vertical in-service prioritization. So how do we make decisions about what we do in the New Zealand healthcare system? And there's a whole lot of that stuff that actually informs what we do and how we do it, right? And that contributes to the inequities that we see. It goes in all sorts of ways in terms of primary care, but you know, there's other things we could look at, like Pharmac and the prioritization. Like, I don't know, let's get elected on a slogan. 27 meds, was it 27? They get elected on the 27 cancer medications. Fuck me. And fortunately, I think Pharmac kind of pushed back and said, those medicines that you want, reach down to here, fund the whole thing down to there. Don't just pick and choose. If we did that, you know, what we'd be going, we're going, well, cancer is more important than rheumatic fever. Cancer is more important than immunizer. Cancer is more important than, well, are all cancers important, or is it just some cancers? Is it cancers which end up being carried in a coffin to Parliament versus some other cancers which don't get that sort of activity? Fuck, it's difficult stuff. But if we just go based on, this is the stuff that's turning up in the media, this is the stuff that I'm getting harassed in my clinic, you know, these are, they're really challenging things. And I think we do that. And that's why I love this report, because they're saying to me, they've had a look at what we did and go, all right, you found an inequity, but do better. Okay, they didn't say stop. I was really glad they didn't say, and we think it's causing harm. Oh, now, what's rule number 1? Do no harm. And, you know, did we have enough robust stuff in play that we could really know that we weren't doing harm? Probably not. But these guys looked at it, and so read the stuff that says, okay, we've looked at it and we don't think there's any harm in there. But anyway, so yes, we've got to bust it wide open. If you're in chat, you can type questions in.
Thank you so much. I was thinking about, so thanks for sharing this experience as well, like what that you were involved in directly. And one of the questions it raises in my mind, it being this report came out and then the policy change was actually not what the report necessarily was suggesting. And one of the questions I think that raises is kind of like, well, why did that happen? Because it's not what the report said actually. And I think we all have our views about the political reasons behind it. But if I'm being really generous, which I'm not usually in this context, I wonder if there is sometimes a kind of conflation or a confusion in public discourse maybe, or something that politicians take advantage of sometimes. And it's between equity and sovereignty, or equity as a health goal, like we want equity for people with disabilities, we want equity for women, we want equity for ethnic minorities, we want equity for people, you pick a group. And the fact that Maoris are a treaty, you know, that's one of the treaty partners, and that's not really about equity, that's about constitutional rights and sovereignty, which is a different type of thing. It's, I think, in many ways different from these considerations of health equity. And I know there's massive overlap, and that's where a report like this falls. Because in one way you could say, well, like the reason to include ethnicity, and particularly maybe to include Māori ethnicity as a factor that you then weight in this prioritisation scheme is because it's a really accurate heuristic for addressing an inequity that we're seeing, a pattern we're seeing. So we can see that pattern. Doesn't mean that we think that going forwards in a better healthcare system will always be giving extra weight to this particular group that we can see is getting short shafted right now. It's just that it's what, you know, it's the way that we're going to address it to fix the imbalance. And that isn't the same as saying going forward, we're going to be giving Maori their own, you know, health, was it an authority that was this?
Independent Māori Health Authority.
The health authority.
Yeah.
Because to me, I know that some of the drive and reasoning for that health authority is most likely these kinds of inequities, but there's also a significant, I think, treaty rights about constitutional rights. It's not really about, you could have no inequities in health and still have a case to be made for having a Maori health authority that was based on other things. And I do think that like politicians right now in New Zealand are kind of, some of them are sort of manipulating those two issues and saying in a sense, oh, what's happening here is that you're not addressing an inequity, you've seen there's an inequity in this way and you're addressing it. You're actually trying to give some people more power and authority, like they're kind of muddling them on purpose.
Yep.
Is that
Cutting you off now?
I'd love to know how you
Pretty good.
think through.
I'm nodding, I'm agreeing with you. And so the right-wing think tanks are testing a whole lot of those things, and you end up in a place where if you can tell people that Māori getting theirs means you not getting yours, okay, you can exploit that, right? If Māori get what they need, somebody's missing out. Okay, so that the politics of that's really, I think, playing out for us now.
Because if we could see that there was a health inequity for everybody who was left-handed, then you might put left-handedness into your priority setting thing to fix that inequality. But that isn't the same as saying left-handed people are a treaty partner and get their own constitutional rights.
The slogan, and it was literally tested in focus groups, needs not race. You could take that race out and go, needs not age. I mean, what the fuck is that? Just because you turn 65, suddenly we give you extra, we just give it. Not all 65-year-olds are needing this free bus card or something. You know, some of them don't need it at all. Some of them are multi-millionaires. Well, we just give it to them. Needs, not age. It should be based on needs. So depending on what your intention is, you're just going to exploit those kind of complexities. But the cost of trying to figure out, oh, he was on the radio. Did you hear him talking about it? Who were you talking to about it? Was it Radio New Zealand? Yeah, it was Wallace Chapman, eh? No. So, you know, here's how we understand these characteristics of need. And so if you could, in a perfect world, everybody be assessed on what their need is and all the rest of it, and then okay, but that we can't do that. That's a fantasy. The reality is that we can go, right, old people, the characteristic of old is associated with these health characteristics or these outcomes. And so it's a reasonable way of trying to figure out how we do stuff without making it really complex and costly. And see, that's the basis, I think, that we want to make sure that we still fund everybody in the primary care system. You know, some people advocating that we just go, well, some of my colleagues, some of my GP colleagues, I'm a GP, you know, I'm in that tribe, I'm going to own it. I've been called a GP hater, but I'm not. I'm just a critical friend to my colleagues. But some of them have said, well, should just be able to charge $200 a consult. Yeah, they've said that in meetings that I've been at, and I get it. They're pushing hard to go really deep into that privatised healthcare system, and they can see a market that they will do very well out of. And you just sat very uncomfortably, and that's me too. I'm going, you know, do we really formally want to go into a place where we have two separate primary healthcare systems, those who can afford it and everybody else? And I don't want to go there. I want to have a system in which all primary healthcare is somewhat subsidised, where all of that data is available to us as a nation. You know, I don't want our primary healthcare owned overseas by some equity fund or anything like that. I want our primary care system joined up and owned, you know, owned and operated. So there's as a sovereign nation, Māori want to have a system that we own and deliver and all the rest of it. But New Zealand as a nation, we should have a system, a primary healthcare system for our nation. Yeah. Okay, so some other ethical, oh, can you stop sharing? We'll just be more like me. I'll be on the screen.
There's a question.
Okay, we'll come to also during the COVID times, a group of Māori doctors started advocating to Whānau really strongly that the new diabetes medications should have an ethnicity criteria in the special authority, right? And up till that time, they've never done it. Well, we've been advocating since 2002 that there should be an ethnicity criteria in those special authorities for specific medicines. We've been advocating since early 2000s that Pharmac should be having a much better analysis in terms of what the potential benefits of any given medicine or treatment are, right? And we don't see a lot of that. But anyway, we got it across the line. They went out to consultation on the SGLT2 inhibitors and the GLP agonists, and I think we did it was a spanner. We just got the spanner and jammed it in, and the consultation came to a grinding halt. We got hammered by our colleagues on that. I had people saying, what you're doing is unethical. There are people who will benefit from these medicines, and you are slowing it down and you are harming those patients, and just go with it like this and we'll help you later on the inequity. I says, fuck off. When did you ever help us on equity? We need this as a principle. And so eventually Whānau came to it. And so Māori and Pacific, HbA1c 53 or above, eligible for these medicines. And these medicines are really important. They're making a difference in terms of renal dysfunction. If you're on these medicines, all-cause mortality falls, you know. This is important stuff. But the principle of getting ethnicity into those special authority criteria, we got it. You know, we tried to get that in terms of the COVID vaccination, and we didn't get it. And our mortality is 2.4 times the mortality of non-Māori, non-Pacific. So, you know, anyway, there's lots of these places where we can have these arguments and we've got to work it out. And Pharmac's one of them. Yeah, sorry. I'll just go online and then I'll come to you in the corner.
So the inequity diagram that you showed at the start represents things like your prioritization tool. A more structural way to address it would be to make a sloping ground or fence that enables people who are shorter or in a wheelchair to find the place that allows them to see, or perhaps remove the fence. So that's from Jim Ross, who is a GP in Dunedin.
Yeah, well said, Jim.
Yeah, remove the fence.
Mm.
Okay, in the corner.
I'm thinking about the last point you made about ethnicity as a determination for medication access. And I'm wondering, how do you think of that as a treaty thing or as a needs thing, in terms of, is it like age? In that there are some people who identify as Maori who are millionaires. And then there's an awful lot of people who aren't, but how do you make then that distinction for the people who are doing quite well, thank you very much, that they have access preferentially?
Yep. Point well made. Which is true across all of our whāmek funding things, isn't
Absolutely.
it? Yeah.
Yeah.
And Māori no different.
And
Yeah.
not just for ethnicity, but like you're talking about with age. I mean, it's the same thing. Just because over you're 65, you don't need a bus card.
But so, and of course there's two parts to what the answer is. One is, I think we've got really good evidence about Māori and Pacific diabetes and bad outcomes. So I think that's the case that we're trying to make. But in terms of how whāmek does its work, I think there is a treaty right in that part of it. So I would privilege certain provocations in the two different parts. And sure as hell there's some rich Māori who are buying Ozempic, and good on them. I don't mind. I can't wait until we can afford it. One of them's coming off patent. It's the SLGT2 inhibitor, isn't it? Within the next year or so. So we might see some downward pressure on some of these drugs quite soon. Denmark's worried about being so dependent on vitamin O.
So the answer is it's more treaty than equity in this instance, in a single instance.
And the new diabetes medicines.
Yeah, in an ethnicity criteria.
Oh no, I think it's health outcomes. So when you look at the epidemic that diabetes is, and it's Māori and Pacific, it's got, well, actually Indian subcontinent has got a particular trajectory, you know, in my clinical experience with Southeast Asian diabetes, from diagnosis to needing insulin, the trajectory is quite steep. So I think ethnicity is part of that, and there'll be a whole lot of complex things. But right now, reliably, you can say that Māori get worse outcomes in terms of diabetes. So the renal failure and all the other things. So I think that is a really good reason for us to be doing better with these medicines for that population. Jim's looking thoughtful. You could unmute if you want.
He says,
Go ahead.
to follow my comment, one question would be, would it be a Tiriti compliant way to address the problem of seeing over the fence?
Yeah, you slightly misread me there, Lindley.
sorry.
What would be? I don't know whether Tiriti compliant is a good concept or not. But if we're thinking about it, if we're thinking about this, I mean, I know this is a bit of a hypothetical kind of model, you know, the fence pictures, but what would be a Tiriti focused way to deal with the problem of not everybody being able to see over the fence?
Yeah. So that's where that meme kind of breaks down, eh? Because education and health are not necessarily games we're going to watch, and isn't it all great that we're all getting to watch it? There's actually engagement. So
okay, let's come back to prioritization tools then. And I mean, that's a temporary expedient in a way, right?
Yeah. And that's where the meme kind of works though, Jim. So that there is a fence, and right now we think this game is going to have a fence. So, you know, we think people need to be able to watch this game, and that is somehow a level of engagement. So the boxes to see over the fence is one way of doing it, or actually take the fence out so everybody can enjoy it. Those are not unreasonable ways of thinking about
Yeah.
access and engagement in education and health. But
Yes, but if you
Clear
have your two whare toa example, then you're having rangatiratanga, aren't you?
Yep.
And the only way I suppose that we can see that in action is to see it in action, in fact. In the meantime, a lot of these things, like, you know, having a few token councillors on local councils and so on, these are temporary expedients. Even Te Aka Whaiora, these are temporary expedients to prop up a system which is not is miles away from being tiriti compliant, right?
Yep, agree. Guilty. I mean,
And
it's
perhaps-
I'm old, I'm going, fuck it, this might not come around again. So Independent Māori Health Authority, I'm all in, you know, like I was I was a claimant, I'm still a claimant in the tribunal 2575. Yeah, so, but today I was asked to come along and talk, and Jim, I think you've caught the kind of nuance of what I'm trying to say, which is there will be times when we're going inequity associated with ethnicity. That is we need to elevate our response to that. There'll be other times when we need to talk about tino rangatiratanga, yep, and the so that pro-equity thing, there's 5 boxes in there, and at least 3 of them I think create opportunities for provocation about what we do and how we do in the health system. So I'll take it as read. You understood what I was saying.
Yep, thank
Thanks
you.
for having me. Peace out.
Thank you so much. Thank you so much. That was really fascinating. And people have got hopefully some time to meet up and have a cup of tea. We've got some food in the tea room, and so we'd love for you to join us. So who's speaking next week? John.
Mr. John McMillan.
Did you know that, John?
Yeah.
Okay, thank you so much.
You just end it. Literally,
Oh, will it do it all itself?
That'll stop the recording.
and I think we must have a setting where